We've all heard it before. Sick care, healthcare is reactive. That's the biggest problem with our healthcare system. But we believe that that is just a symptom of a much bigger problem. I'm Taylor Cushman. I'm an internal medicine physician.
And I'm Rachel Cushman. I'm a physician assistant.
And this bigger problem that we're going to talk about today is what drove us to start Paragon Total Wellness. And we want to share some of our experiences that led us to this point.
So, as a physician, you said before that you believe that our issue with healthcare currently is that it's not a lack of information. And so, when you say that, what experiences do you draw on that make you think that?
Yeah. And it's interesting because this should be the most exciting time ever to be in healthcare. We have so many awesome technologies that are coming through so quickly. We have like all the wearable devices, there's so much information, but nobody is using it right. And I think so often it becomes a distraction. And to give some background to that, uh, I started medical school. I went to medical school because I wanted a profession where I could help people. I wanted to meet people in a time of need and have the skills and knowledge to be able to support them through a really difficult time. And so originally in medical school, I was interested in radiation oncology. It's a really small field as a cancer doctor. And the reason I was drawn to it is because, in my opinion, it's probably one of the most intimate relationships you can have in the medical world. You are helping people through either curative treatments for their cancer or palliative treatments at end of life to preserve their as much quality of life as you can. And I mean, it's heavy and it's real.
Mm-hmm. And I
And
remember specifically you training, and really, you didn't have a lot of inspiration in medicine at all until you did your first rad onc rotation and you saw what that relationship was like.
yeah,
And it was the first time that I felt like you really had something that drew you to medicine, gave you an inspiration.
yeah. And then life took us in a different direction.
Mm-hmm.
Rachel got pregnant, and we decided we want to stay in Phoenix. And so as a result, I stayed in Phoenix and did an internal medicine residency. And I saw more of the, instead of connection and helping people through hard times, you just see this revolving door of the same types of patients over and over again. And it's the same patterns of sick, and they come in and we put a band-aid on it and another medication and we send them on the way just for them to come back in a few weeks.
Yeah, and it worried me initially because I didn't see the same excitement for medicine when you were working internal medicine, because you didn't have that relationship with patients that you wanted, that you saw that you would have with radiation oncology.
Yeah, and it's a system problem too. It's not like the patients in that you're seeing in internal medicine don't want that connection too. It's that you either don't have time, you don't have the resources, you don't have the health education material. It just, you're set up for failure, and the patients are set up for failure. And so I finished residency and I thought, okay, I don't love the whack-a-mole healthcare reactive piece of it. So I got this job that I working in inpatient psychiatric and the detox facilities, and hoping that maybe the mental health and addiction world was different, and it was more of the same. So it was the same revolving door. It was going down the formula of medications, and instead of actually looking at who's in front of you and what does that person need and how can our system help support that person, discharging the person who's addicted to whatever their drug is to the streets with nowhere else to go and is surrounded by the exact same thing. We're just setting people up for failure. That's when we started looking in the preventive care world and trying to figure out, is there somebody that's doing it right? And we looked far and wide, and there are people that are doing good work, but it seems like, especially the preventive care, and as soon as you use the word wellness, someone's trying to sell you something. They're either doing 200 plus biomarker home lab draws, or they're giving you this wearable with all of this information. I mean, I love the wearable devices, and I think it's such an interesting and exciting field, but just giving people information, but not equipping them with the how to handle it. It's more of the same. It's just people aren't actually getting better from these things. And so at a certain point, we said, no, nobody's doing this to the standard that we want. And so that's when we decided that we were going to start Paragon Total Wellness.
Okay, and before we get into what Paragon is exactly, let's give a little bit more of that backstory. And so, one story you told me a couple times is, and I think to get the full picture of your experience in medicine, we have to start in residency, especially because residency for you was during COVID. And so it was kind of even more of an extreme example of what people go through in residency. So um, there's one specific story that I know that you thought really summed it up well. So I'll let you tell it.
So to give some background on what internal medicine residency training was like for us, I started in 2019. So right in the middle of the 3 years of internal medicine residency, 2020, Avery was born in March. And they basically said, internal medicine residency is on pause, and you're now a COVID ICU doctor, and you're going to be working as much as we need you to. And so it was the 100-hour weeks. It was death and dying, and family members couldn't come into the hospital to see their loved ones. So there was these 12-hour shifts plus running through the hospital. This patient's going to pass soon. When they do, take the ventilator, bring it to this other machine or this other room. This patient's going to need. We're low on feeding tubes for people that are under sedation because they're unable to feed themselves. It was a horror show, and we would get in the middle of all this. We would get these lectures, these wellness lectures, and I mean it almost became comical. We had to laugh at these things because it's usually the lectures would be in the middle of your really busy morning, and you're trying to see all the patients, get all the orders in, call the consultants, make sure everybody's stable, get the documentation, get the medication orders, and it was crazy, and all before your attending got there to start rounds. And you'd get these wellness lectures, and they were mandatory, of course, and you sat down, and it's like always the same one of 3 or 5 things. It's like we meditate and deep breathing, and use the Headspace app, and it's just like I told you, it was like one time I was so tired driving home, so exhausted in ways that I didn't know was possible. I felt dizzy and confused. I couldn't remember what exit to get off on the freeway.
I remember this.
For several minutes. It was such a bizarre feeling of dissociation and disconnect. And they didn't mention that in the wellness lectures, but we had one of these wellness lectures. I mean, I think about it. I still think about it almost every single day, and it makes me emotional. Like Steve Brown, he was, I don't know if he still is, the chair of the family medicine department at Banner. He gets up in front of the residents in a lecture, and we all think it's going to be more of the same. And he says, telling residents to meditate and do yoga for wellness through residency is like telling a canary in a poisoned coal mine to hold its breath. It might work for a little bit, but eventually you're going to have to take a big breath in, and you'll be affected by it. And he was the first person to ever say out loud in the traditional medical education system that our system is broken, and it's not, and it's designed, it won't let you be well if you're in it long enough. And it was such a, it was more than just validating. It was so, like, everybody knew it, but it wasn't something that we really, nobody had said it out loud.
Yeah.
And ever since then, I guess that was what really sparked the beginning of me internally thinking, well, why does it have to be this way? If the system is broken and making us sick, then what are we going to do? Do we fix it within the system, or do we seek out of the system? And so if we're in a system that's making the residents, the medical trainees, and the physicians and PAs and all the staff more sick, then if it's making us worse, what is it doing to the patients?
So there's a specific patient interaction situation that we were talking about that is kind of like in regards to this, and a good example of this kind of system. Do you want to tell us the story?
Yeah. This is another one that I probably don't think about this on a daily basis, but every week, this person comes to mind. Our clinic, so our outpatient setting. So in internal medicine, most of the time we're in the hospital, and sometimes we're in the clinic. I think it was once every other week or once a week, depending on the schedule. But we'd get new patients, and they'd come in, and it was usually the flow of it was every now and then they have medical records, but usually not. And they would have a long medical history, the nature of why they were brought to the internal medicine as opposed to a family medicine clinic for their primary care. And I had this guy, and he was younger. I think he was in his 40s, and he came in, and we're going through his medical history, and he doesn't even lead with it. One of the things he says in the middle of a list of maybe a dozen medical conditions is his words were organ transplant. And kind of paused, and I couldn't tell if he was joking or not because he just said it so nonchalant. And organ transplant, he knows I'm going to want to know which organ. So I asked him, and he did not know the answer. And this is, mind you, not somebody who has some cognitive deficits, some traumatic brain injury. He actually didn't know. And I tried to understand, well, what led to you getting it? And it was the vague, well, I got really sick. I had to be in the hospital for a really long time. He couldn't tell me. And so, where on your body is it? And, we look at the scars, and he's had a lot of abdominal surgeries, and it wasn't clear. So, of course, we sent him to the emergency room because you need to be on immunosuppressant medications. And he hadn't been on any for at least a year. And he never came back to clinic. And the reason he stuck with me for so long, and still sticks with me, is, of course, we are all accountable for our own actions, our own health.
Mm-hmm.
But what kind of system will take one person's organ and transplant it into another without it being absolutely ingrained in their mind what it is and why it's there and what it's doing and how to take care of it?
Or what kind of system allows the disengagement to happen to where you get to the point that you don't even care or know? Or
Right. Yeah. Yeah. And I mean, I without judgment, he was so disconnected
mm-hmm.
from his health, and there are probably a dozen reasons for that. But that disconnect was this theme that you and I have talked so much about, that we just
mm-hmm.
keep running into
mm-hmm.
in every aspect of it.
Mm-hmm. And it's an extreme example, but it's also like, is there a world where medicine functions differently, where there aren't examples like this, where people have a real relationship with their doctor, their personal doctor, their primary care doctor, to where at all times they're engaged and they know what's going on and they have a plan and they have a real relationship? It just doesn't exist.
I know you've had a lot of experiences in your women's health job that we've talked about that have had similar issues. Do you have any specific patient experiences or just general themes that you
Mm-hmm.
saw in the women's health world that were similar to that?
Yeah, so I think, right out of PA school, the first job that I went into was women's health. And I worked at a high volume, really fast paced OB-GYN clinic. And, when you're right out of school too, you're very much taught to follow the guidelines that are available to you. It's you you're working in such a fast paced environment that that's what that's what you have to go off of. That's how you're taught. It's essentially like a machine. You're seeing a patient every, in obstetric care, sometimes the patient visits are only 10 minutes. And most of the time it's, an easy follow-up visit where you're just making sure everything looks good, they're good to go, but not always. And then when it's not, and you have a 10-minute time slot, it's really hard and it's stressful, and the system doesn't help that. And so I think there's also the aspect of it too, that in women's health, a lot of times you are the de facto primary care doctor for most of your patients. A lot of times, especially young women, they're not seeing a primary care doctor, they're seeing you. And so not only are you seeing patients in an extremely sensitive, vulnerable time, but you're also having it rushed, and you also have that added pressure of you're the one provider that they're seeing. And so I think my initial experience in healthcare was essentially that. Like, I had really meaningful moments, but it was all within a very stressed, high pressure system.
And you've told me about some of your favorite types of patients when you were working in women's health. And anyone that knows you and anyone that's been around you, especially when you get around your siblings, would not be surprised that this involves a lot of conversation and a lot of talking. Um, do you want to tell everyone about what those interactions were?
So one thing that I found working a couple years into OB-GYN, and I started working at a new clinic, and they had asked me when I started there what kind of patients did I like seeing the most. And a lot of the providers there kind of had their little niche of things that they like to do. And essentially they wanted to know what was my favorite patient. They would try to put more of them on my schedule. And for me, it had always been young women, specifically like annual visits if it was the first time that they had ever sought healthcare. They'd ever had maybe a gyne exam for the first time. They were nervous, especially. I liked being able to have that opportunity. I think being able to make that connection with patients, knowing that that could change the way that they access healthcare forever if they felt comfortable when it's something so sensitive and it's an intimate type of healthcare. It's something that a lot of people maybe dread doing. And if you can be the person that makes them feel comfortable and have that trust and build that connection with them, that felt meaningful for me. And in a day of rushed visits and stress and feeling really annoyed with the system, I really found meaning in those visits and those moments.
Yeah, the connection pieces is what we just keep coming back to. And I think most people have had that experience of disconnect with the system at one point or another. But just to illustrate how severe it is and how exhausting it can be, do you have any specific patient encounters, interactions that you can talk about that talk about the disconnect that we often see?
Specifically, one comes to mind when I saw a woman for a breast exam. She had had a normal mammogram. She had a normal mammogram already on file, and it was within the last year. And she had had a small like area that she noticed she was having like some pain in the area. So just to cover the bases, I sent for additional imaging. They had recommended a biopsy of the area, and the fact that she had already had a normal mammogram, um, we weren't that concerned about it. I remember the day was super, super busy. It got to the end of the day, and I had actually received the results after she had had her biopsy that it did come back positive for cancer. And because I wanted to get her in with the breast surgeon immediately, um, I didn't wait to have a visit for her to come back in to tell her the news. I ended up calling her and letting her know so that she could be prepared to go see the breast surgeon. So I ended up telling her over the phone about the results. And I just remember feeling that, I was with her to this point, and then it was kind of like, letting her go into the system with the oncologist and the breast surgeon. And I don't know what ended up happening with her. Um, but just that feeling of, you know, something so personal and life changing of getting a diagnosis like that, but it being over the phone and me never having seen her again after that, it sticks with me that, you know, in the moments that it felt good and that connection was there, it didn't in that moment.
Yeah, those sorts of experiences where you can't offer the support or the compassion or empathy that you want to have the opportunity to do it is I mean I can't, there's a term and I always, it's something like moral fatigue or moral decay
Yeah,
that
like
talks.
empathy fatigue.
Yeah, and it really does, it slowly it wears you down in a way that is really hard to understand until you've experienced it.
Because this system makes it that way. It's not because you don't have the capacity to feel it. It's because the system essentially removes it and doesn't allow it.
Yeah. And when you talk about that, it reminds me of a patient encounter that I've told you about before. And I was a medical student, and I was doing a radiation oncology rotation. And as a medical student, you usually go through all the records, and then you talk to the patient first. You get the pertinent details of it, and then you go present it to either the resident that's going to see them or the attending. And so in this instance, I was working with the senior resident on the team, and so I went to see this guy, and young guy, and he had two beautiful kids, wife. They'd driven down from a small town in northern Arizona, and he was there for a consult because he'd been having a lot of sinus pain and pressure. He ended up getting an MRI, and he had a huge mass that was like, it was encompassing, a really major portion of the inside of his skull. And he was really scared. And we talked, and I just got the information I needed. And his kids are holding his hand, his wife is, and there's tears all around, and I don't have any answers for him. And I tell him, like, hey, I'm just a medical student. I'm going to gather some information, and then the resident will come in to speak and be able to provide some detail. And so the resident comes in. Well, I fill the resident in outside of the room, and then he comes back in with me, and the guy, this guy asks the resident, he says, what's your first name? And the resident gives the first name, and he says, do you mind if I call you by your first name? And this was not a disrespect or anything. This was like he
was looking for some humanity in the situation.
Yeah. And the resident was and is a good doctor. He cares, he's kind, but he said no. And then he just went right down the list of things of, this is the most likely type of cancer, and if it's the case, this is, and it was just this formulaic thing. And this guy, like, the way he was like bracing his kids, and just in that moment just wanted some support and some connection, and then just to deny him of that, I was just like, how did we get to this point?
But on your point about the empathy fatigue, as a radiation oncologist, and you're saying, this resident is a good doctor, and it's like, there's probably an aspect of that where you have to disconnect at some point so that you're not having a breakdown with every single patient that you see. And so not to.
Yeah. So that was in the oncology world. And then after residency, I'm working in the mental health world. And one of the facilities I work at is, there's a large population of unsheltered people that live around it. And there are a lot of people who are frequently readmitted. And I remember one guy who he would come in at least once a month. And it was the same thing over and over again. It was fentanyl. He was addicted. He was living on the streets. And he didn't qualify for any services or support when he would leave. So they would discharge him back to the street. And I mean, he was a soft-spoken guy, and him and I had good rapport. We always did. And one time I asked him, how are we going to get you out of this cycle? And he told me the story of how he was in that cycle. And he'd had a really hard life. He had no family. He had no experiences. I think he'd had a couple, everything was working against him. And when he would get discharged, they would give him a bus pass. And they'd say, here's a bus pass. Now you can take it to go to the shelter and you can go get a job. But at every bus is fentanyl. And so one of the most addictive substances, and every single place he goes is this.
The only resource he has.
Yeah.
And leads him right back to the problem.
So it's like, how is he, and so it was another thing. It was the system is so disconnected. And it's not any one place. It's not like this one facility is doing wrong and everywhere else is doing better. Mm-hmm. It's a system. We don't have support. And so this guy, he had disconnected. I mean, personally, he had disconnected most of the time. He just wasn't there. And the system had disconnected from him, and it was just, it's awful. And I was speechless. I had no answers. I didn't know what to say other than to just be present with him in that moment.
Mm-hmm. So I think reflecting on like all these experiences that we've had in medicine so far, and any couple that is also like both in medicine knows that a lot of the time, a lot of your relationship is commiserating together about what it can be like. And I think one thing that we always come back to is like the connectedness with patients. And I really think that that's what brings meaning to it. And when there's meaning in it, that's how we give the best care and how we avoid the burnout and the empathy fatigue. And so reflecting on all of that is what brought us to where we are now, and thinking of our two young kids and you specifically turning 40 and having your existential crisis.
Good.
And what we want our life to look like and our work to look like. And that's really kind of what brought us here now and why we started Paragon.
Yeah. And we mentioned at the beginning that the problem is not, the driving problem is not that it's reactive, is that it's sick care. Underneath that is the problem is the disconnect. There's no connection. And you can think of it in one of 10 different ways. The system has disconnected from it, the medical professionals, the nurses, the doctors, the PAs and NPs, all of the supporting care staff. The patients have disconnected from the system because the system abuses them and some and neglects them and mistreats them and speaks down to them and delays their care and makes it inaccessible and all these things. So people, they're just like, I'm gonna unplug from this. This isn't working for me. And then they're the ones that suffer. And then people get on another end is they get an endless amount of information, whether it's through these home lab draws and their wearables, and they get one doctor telling them something, they get another doctor telling them, and so it's too much information and they disconnect. And so everywhere you go, it's like everything is unplugged. No one is putting it all together and no one is seeking the humanity in all of it. And I think if you have that person, or if you have those people, if you have that care team, it doesn't have to be like that, even if you're seeking care through the broken system. And so that's when we said, let's do this. And we started Paragon Total Wellness. And our philosophy, that where we always start from, is how do we help people connect with themselves, and how do we help people connect with the system? And so that's where we are, and that's all I think about all day long. That I have a hard time unplugging, and it's because I think that there's such an amazing opportunity for us to create this model and set an example of how this should be, and restore the connection to people's own health and to the connection with their healthcare team.